Welcome, everybody. Before we get started, I just want to say that everyone loves their gastroenterologist and hepatologist by extension, because you all bring to very difficult situations your inspiration, your brilliance, your empathy, and your humor. And so let's give you a round of applause for that. All right, so now that I made you happy, I'm going to make you mad, because the most inspirational, the most empathetic, the most brilliant, and the most humorous patients, of course, can be found, and providers can be found in the IBD space. And that's a panel I'm going to introduce right now. To start off, let's bring out Dr. Ariel Jordan, who's an internal medicine resident of University of Michigan, accepted to a GI program. Come on out, Ariel. Next up, I'd like to welcome out Mr. Marquis Ellison, an IBD patient advocate, certified personal trainer, and nutrition coach. Coming out. And last but not least, we'd like to welcome Dr. Tolulope Falaiye, assistant professor at University of Colorado and National Scientific Advisory Committee's member of CCFA. Please come on out. All right, and so as we've already agreed as a group, the IBD community is an amazing one, but we're going to talk about the fact that before a person realizes that they're actually part of that community, we know that sometimes there's this barrier of diagnosis that we talked about. We know that the workup rate for African American patients who have IBD is 10% of our Caucasian counterparts. And so before we can get to community, let's start with the personal stories. And let's start with yours. If you can just walk us through, Ariel, some of the early stories, symptoms you were having, and your journey and difficulties towards eventual diagnosis.
Yeah, so for me, I got my final diagnosis in October of 2015 of ulcerative colitis, but it took a long time to get there. I had symptoms of blood in my stool from around probably age 9 to 10. And unfortunately, my story is not, unique, especially in the minority IBD population and patient community. But my mom took me into my pediatrician's office when I was having those symptoms, and really, my doctor just kind of said, it could be this, it could be that, but no one really thought about IBD, and especially, this was like, nearly like 15, 20 years ago. So I mean, especially like a young black girl coming in with blood in her stool, is anyone really thinking about IBD in her? We've come a long way in terms of knowing that IBD is a disease that affects diverse populations, but really that wasn't what we were thinking at that time. And so I kind of continued on throughout my life, kind of with these symptoms of blood in my stool off and on, and abdominal pain, and that kind of became my norm. And then finally in college, I got to a point where I was having bloody stools every day. I was having a lot of abdominal pain. It was really hard for me to get to my classes. I was extremely fatigued. I lost a lot of weight. I had become anemic. And finally, I was able to see another doctor, and she finally said, she was actually a Latina doctor, and she told me, like, these symptoms are not normal. You should not have blood in your stool. You should not have lost 25 pounds. Like, none of this is normal. And so finally, she was the one who said, you need to see a gastroenterologist. And so finally, I saw a gastroenterologist. She recognized the symptoms right away, and I finally was able to get a colonoscopy and get my diagnosis of ulcerative colitis, which at the time, I was excited to have a name for the symptoms that I had had for a good part of my life, but it was also scary because at the time, I didn't know anything about IBD. I didn't have any family members that I knew of at the time with IBD. I didn't even know what this disease was. And I remember just kind of after my colonoscopy being told this is what I have, getting a sheet of paper with things that I probably shouldn't eat, and kind of being told, okay, kind of go from there. And we need to start some medication, and we'll kind of go from there, and we'll see what happens. And so, I felt really alone. And I remember feeling really alone in that and wondering, are there other people out there like me? And and I think, for me, what was really exciting was my doctor actually told me about there's this organization, the Crohn's and Colitis Foundation, and the following year, I actually participated in their walk, the Tate Steps for Crohn's and Colitis Walk, which a lot of you may be familiar with. And really, that was the first time that I was able to see other people like me. There are other people out there who have this disease. There are other people out there, and being able to talk to the other people and hear their stories and hear other people who've had similar experiences to me, that was really great for me, and it was really comforting to know that I wasn't the only one, out there, and that was really the start of my journey.
Excellent, excellent. Marquis, I know your story. You want to share it with our group today?
Yeah, sure. Good afternoon, everybody. So I was diagnosed with Crohn's disease in 2009. And, similar, I had all of the symptoms, rapid weight loss, and, the other symptoms that's associated with IBD. It was a second opinion that led to my diagnosis and getting me started on that medication. The second opinion came at a time where the first GI doctor kind of failed me, and it shouldn't have went that long before I got a diagnosis. But nonetheless, I got the diagnosis, got started on the medication, and just been controlling it and fighting it ever since.
And so you had actually seen a gastroenterologist, but they still failed to make the IBD diagnosis. How long were you seeing that first gastroenterologist before you were eventually switching over to a second provider?
So I would say my symptoms started about early January 2009. By the time I saw my second GI doctor, that was in August 12th to be exact. I'll never forget the day I was diagnosed, because that was the day that Michael Vick had made his debut back into the NFL. And his press conference just happened to be on the hospital room. So I could never forget that day. But leading up to that, you would say from maybe January to August, when I got diagnosed, that my first GI doctor missed the mark.
And Dr. Falaiye, you're hearing these stories of us being told to normalize our pain and to just accept the bleeding in the stool and accept the pain and discomfort literally. What are some of the stories you've seen in your space as a pediatric gastroenterologist, and how are some of the ways that these diagnoses are popping up in younger people that we as providers need to be aware of?
Yeah, I think it's really important to know that children are not little adults. They present differently. Their disease may need to be managed differently depending on what's going on with them. So in the pediatric space, some of the things we see are that kids may stop growing. I remember a set of twins where one twin was a foot shorter than the other. That twin had IBD. I remember another kid who he came in because he couldn't sit down, and he had awful perianal disease. He had also lost 40 pounds. He was overweight beforehand, and it just kind of seemed like people were like, eh. But he lost 40 pounds and couldn't sit down. He was having that much pain. I think of another kid who had delayed puberty, and that can be a marker for IBD in children that doesn't really get looked at in adults. And so these are just a few examples of some of the things we see in children that a pediatrician may see, or their primary provider may see, that should warrant at least a phone call, but probably a visit to a GI doctor.
And so, of course, when we think about our little child, for those of us who have kids, and we see blood in the stool, probably psychologically, no one wants to believe it's more than just hemorrhoidal irritation. At what point should a person say, hey, this is not normal, as Dr. Jordan said, I have to get in front of either my primary care doctor, my pediatrician, or an actual gastroenterologist for further evaluation?
Yeah, that's a great question. I think, as it was mentioned earlier, if you're seeing recurrent blood, that's not normal. And then the next step, typically the first time I see someone, if I don't see any other signs, I say, let's soften your stool, see you back in a few months. And if it's still present, that buys you a screen. In children, up to 20% of children can have normal labs, including ESR-CRP. And some children will always have a normal CRP, even when they're actively flaring. So we can't depend on these tests alone to screen for or against a scope. We do use fecal calprotectin, as is used in the adult population, and if that's elevated, that buys you a scope as well. And so I would say that knowing that this can happen, and for the people in the room who are not aware, there's actually an entity called very early onset IBD, where children 5 and below have IBD. This is a real thing. And so we don't want to wait years and delay a child's potential for growth and development and decrease their participation in life, school and social activities, because they're having all these symptoms. We want to act in a timely fashion.
That's excellent. Yeah. So I think it's a great point to say it doesn't have to be all or nothing. It doesn't have to be a diagnosis of IBD on the spot. And that if it is hemorrhoidal bleeding, then it should respond to hemorrhoidal treatment. But after a while, if your intervention hasn't made a difference, if time is passing and you're still having these symptoms, then yes, a benign symptom should be looked at. And it doesn't have to be colon cancer. It could be an infection, it could be inflammation, it could be a polyp that's bleeding, but whatever it is, it's time to take a look. And so I try to, de-escalate the moment by saying, we're not necessarily going hunting for cancer. We just want to understand why you're having these symptoms so we can treat you better over time. All right, and so now we're going into the topic of going from science to actual access when it comes to our pharmaceutical agents that we use. And you briefly mentioned this topic, both of you. What medications were you placed on initially, and what was your story in terms of starting meds as an IBD patient and then going from there?
Yeah, so I was originally started on mesalamine, and I've been really fortunate to be controlled on mesalamine. I've needed the suppositories from time to time for small flares, but in general, I've been fortunate to be well controlled on that. But when I was in my first year of medical school, I was starting in Georgia, and everyone knows how stressful the first year of medical school is. And I went to my pharmacy to pick up my medication as normal, and they told me it was going to be $1,000 for my meds. And everyone knows as a medical student, you don't have $1,000 for your meds. And even if you're not a medical student, you don't have $1,000 for your meds. And so I didn't know what was going on. That had never been the cost for my meds. So I went home and I called my insurance and I said, well, I don't know what's going on. I tried to go pick up my medication like normal, and they told me it was $1,000. And they told me, well, we're really not covering this, this brand of medication you're on anymore. We found something that we think is cheaper and it should be pretty equivalent for you. And so we need you to go ahead and try that. And I told them, well, I don't really want to do that. I've been controlled on this med for years, and I'm starting my first year of medical school. Like I don't need to be going through this right now. And they said, well, this is what we need you to do. This is the cheaper option, and it should all be fine. And as you may have guessed, it was not fine. I went into a flare almost immediately after starting that med, and I missed school because of that. I was struggling, and I called them, and I finally said about a week later, this is not working for me. I almost immediately went into a flare on this med. This med isn't doing anything for me. I need to go back on my original med. So they said, okay, we'll cover that for now. And so I was able to go back on my original med for the next couple of months, and then the same thing happened again, where they said, we got something else for you to try. Again, it should be pretty similar. And I said, well, I've gone through this already. And as I've told you, I'm a student. I don't really have time for this. I've been missing school because of issues with this. And I had a med, and I'm on a med that works for me. And they said, no, we need you to try this again. And these trials kept going on for about 6 months. And then finally, I got to a place where I was able to find, my gastroenterologist was able to find another similar brand of mesalamine that worked for me, that also they were willing to cover. And fortunately, I was able to stay on that for the next several years, when the same thing unfortunately happened again fairly recently. And I'm finally on a med again that's working for me, but this has continued to be an issue over time. And I think this is a story that's all too familiar for a lot of us who are patients out there, of being on a med that is working for me, or having a med that your physician is saying this is going to be a great med for you, and it's not covered. And so that's why I do a lot of the advocacy work that I do. It's personal for me. I've been through this myself.
So Dr. Falaiye, you've heard her story. Are generics the enemy? Are biosimilars the enemy? What's your philosophy? How do you talk through these options and these issues with your patients and their parents when it comes to generics and biosimilars?
This is such a challenging topic. So for the people in the room who don't know, a biosimilar is when you have a medicine that is similar to what we call the originator, the original medicine that's made. Our biologics are antibodies, and so the process by which that antibody is made is considered part of the process and part of the patent. If you were in Europe, you would actually not have a choice about switching because the government just switches you. And we have looked to Europe to see how the trials have played out for people who are switched, and whether they continue to respond to these biosimilar medicines. In pediatrics, first of all, let me say that most medicines do not have what we call a pediatric indication. Pediatric indication means the FDA puts their stamp of approval on a medicine to say, you can use this medicine in an under 18 age group for this reason. Most of our medicines are what we call off-label. And so in pediatrics, when I have a patient who I need to start, I start with what I know I can get covered. Sometimes that may not be the one that I would prefer, but if I try the one that I prefer without going through what's covered, I know it won't go through. And we don't want big bills for our patients and them to start on something and have to switch, exactly as you're saying. So typically, we're going to start, if we have to do a biologic, with infliximab or with adalimumab, which have a pediatric indication. I will tell you there's a delay of something like 9 years between when an indication goes in for adults and when that indication will go in for kids. And sometimes adalimumab just got the pediatric, the second pediatric indication 2 or 3 years ago. And so this is a challenge. This is an ongoing challenge. Sometimes we also just get a notice that says, by the way, we're not covering this anymore. You have to switch. We do try to fight this with appeal letters, and depending on the insurance, we're variously successful. We also, in pediatrics, have to aim for higher doses in some medicines because kids are not little adults. Sometimes they need higher levels, you might have heard of, or they need higher frequencies than would be given in an adult. And so this really makes it different in terms of that fight, because now not only are we using something that may not be approved for that indication in that age group, but I'm asking for more of it than is the standard, than is actually on the label. And so we do face these challenges in pediatrics as well. I want my patients to get better, and I'm gonna fight for whatever it takes to get them better. That being said, I know that we can make the path a little easier if we start with something that I know they'll cover. But you guys know insurance changes what they'll cover, it feels like annually, and then the fight starts all over again.
So, Dr. Falaiye, if I have a patient who has hemorrhoidal discomfort, just a little pain or itching, I can write a script and they pick up the medication that day, and by that evening, they're feeling better. You mentioned delays with both approved and non-approved medication when there's a little bit of a struggle. How long have you had patients had to wait while the insurance companies are saying no when the patient and the doctor say this is the medication that the patient should be on?
Yeah, this is a great question. So my colleague, Dr. Brad Constant, actually put out a paper that was presented last year to address this issue of when insurance denies specifically biologics. It basically delays care because the patient ends up on that medicine anyway, but it increases discomfort because the patient is missing work or missing school, having symptoms, flaring, in the hospital, sometimes having surgery, and doing all these other things that could have been avoided or shortened if they had just paid for the medicine in the first place. In terms of the delay, it really depends on the insurance and the age. So I talked about very early onset IBD. It has taken months to get some things approved in that age group. Typically for something more like infliximab, which by now you would think would just get covered, shorter, maybe more in the 2 to 3 weeks time frame, but that still feels to me too long for something that we've had around since 2000, 1999, and we know works and we can try right away. I will say once a medicine does not work, it does seem that we have better efficacy for getting those next medicines that are off-label as soon as I can say the patient had all of these symptoms and had to be hospitalized for this, they seem to respond a little bit faster for those next levels. We also go to peer-to-peer much, much faster in terms of that next medicine once the first one didn't work because it's off-label.
Can you explain the peer-to-peer process?
Of course. Peer-to-peer is when an insurance says, no, we don't want to pay for that. And so then the doctor has to call the insurance and talk with a person who is not, unfortunately, not often a doctor and maybe not even like someone familiar with the IBD space. And so I have had conversations with a representative from the insurance company who suggested we'll say ineffective testing or ineffective medicines, and we have to educate that person on why that's not a good option for the patient. Sometimes it's a nurse, sometimes it's a pharmacist, sometimes it's a doctor, but not a GI doctor. And we have to just go to bat for our patients to say, cover this. We have made some changes in our institution where now we have a team of people who work on those authorizations ahead of time. So by the time I'm getting there now, it's like the second round of appeals, not the first round. But it's extremely time consuming and it leads to delays in people getting better, unfortunately.
All right, Marquis, what's your story in terms of you being considered for medications, and how did your conversation go with your provider in terms of deciding what the best treatment was for you?
Yeah, great question. So post-diagnosis, me and my GI, the second one that made the diagnosis, in like 2 weeks, we had a great relationship. And, this is one of the things I always advocate for, people that's newly diagnosed with these diseases, is having a great relationship with your HCP is crucial in you helping to manage your diagnosis. So we started with an oral. I currently take Cimzia, which is what I started after the oral. But when I was first diagnosed, he was pushing this to me, and I was like, no, I don't want to take no injection, right? I wasn't injecting myself, and that's what Cimzia is. It's a self-injection. It's not an infusion. So I was just like, no, I'm not going to do that. No problem. He listened to me, and we agreed that, okay, we would try the oral first, which I was taking Lialda, is what I was prescribed. And after the first year, we'll do a scope, and if he doesn't see any improvement in the inflammation, then he wants me to start the Cimzia. That's what happened, all right? So a year goes by, I get the scope. Even though I'm feeling fine, there's still inflammation there in the colon. So we started Cimzia. And what I appreciate about him is, again, he listened, and we had an agreement. And then after I was on Cimzia for a year, the next year's colonoscopy, he compared it to the previous year to show me the improvement. And every colonoscopy that I did annually, he would always show me the previous so I could see how the medication is working. And so that was the experience I had after being diagnosed, with getting the treatment, was him being receptive to me wanting to not jump on the biologic right away and trying what I felt comfortable with, right? And then that's how we attacked that. And I'm still on Cimzia till today, like 15 years later, well, 14 years later.
So I think that's a great example of shared decision making with your patient. As any of you parents in the room know, you can tell your children what you want them to do, but it doesn't work. And so you're going to have to reason with a rational human being who's making rational decisions. And so I like the fact that there was a contract made of sorts, which is to say, okay, this is not no forever, but this is just a no for now. And a conversation and agreement that if one way didn't work, that in a little bit you could revisit what the next best options could be. All right, so Ariel, you are also Dr. Jordan, and so which I love your dual perspective. And so as a provider now, when you see patients either in the hospital as a resident or in your GI clinic, what are some of the options that you have available in your tertiary care center in terms of helping your patients out? And what are those conversations like? Are people understanding they need to start it? Is there a little bit of a pushback? How is that all playing itself out?
Yeah, so at the University of Michigan, we have an inpatient GI service, actually, which is very fortunate. And so patients, a lot of the patients that we end up seeing on that service, in addition to liver patients, are IBD patients. And a lot of those patients are quite sick. They're They've often failed many biologics, or they've had kind of complex courses with their IBD. And we kind of have two big ones that we use for rescues. And so Remicade is one of our, infliximab is continues to be one of our meds that we use for rescue. A newer one that we're using now for rescue is Rinvoq or upadacitinib. And so those are kind of our two big ones that we're starting in the hospital after steroids to try to rescue people. In terms of in the outpatient setting, it's sort of dependent on the patient. Again, it's that shared decision making. I've kind of seen a variety of approaches depending on kind of the provider and the patient. And I've kind of seen the approach of offering everything and offering the full menu of medications and kind of telling the patient, these are all of your options, and you can kind of tell me what you think is best, or there's, a little bit more guidance in terms of like, these are the options, but I think we should probably start here and saying this is where I think you should start. And then there's somewhere in the middle where it's like, these are the options. I think you could start here. What do you think? And so, and I guess, I think that probably the middle approach, I would say, is probably the best approach. I think even thinking about myself, kind of putting on both of my hats as a patient, kind of getting all of that information and just being told these are all the options. There's a lot, as we all know, there's a lot of IBD meds out there now. And so it's hard to know as a patient, especially you're just being told this is everything, you pick, you tell me what you want to do. That's incredibly overwhelming to just say you decide what medication you want to do. Well, it's you're the doctor, give me some guidance. And so I think some guidance is important, but also not kind of taking that parental approach of you need to start this med, because as Marquis was saying, not everyone wants to inject themselves. Not everyone wants to do an infusion. It really, some people are I want to take a pill every day. That's probably the best approach for me. Or no, I'd rather go to an infusion center. I don't want to poke myself. And so I think really it's important to really have those conversations, and it be sort of there'd be some guidance, but there also be a lot of listening, which I think is something that we've talked about a lot today, is there needs to be a lot of listening as well.
That's excellent. So Ariel is bringing up this concept of personalized medicine. And you've talked about, again, some of the go-tos with the medications that you use. It bears noting, like you said, these are medications that have been accessible to adults since the 1990s, early 2000s, in terms of us getting indications for both Crohn's and ulcerative colitis, and these are just happening now in the ped space. But when patients have failed those, are you able to get them the other categories of medications, whether it's anti-integrins, the anti-interleukins, the JAK-STAT inhibitors? How is that all going in terms of personalized medicine for your patients who need something beyond the anti-TNFs?
Yeah, that's a great question. I completely agree with the shared decision making. I will tell you that in the pediatric space, that shared decision making is not just the discussion with the parent. I'm also looking to see the kid's reaction as I talk about this medicine. Because if we say shot and the kid's eyes get this big, maybe that's not the best option to go with. We haven't talked about enteral nutritional therapy, which we use in the pediatric space more so than I would say my adult colleagues tend to use. But that is something that comes up for us as well. In terms of the ability to get these medicines that are off-label for children, the drug companies have become more aware of that delay and are getting kids into trials sooner than in the past. And so we're hoping that delay of indication will shrink. We can get kids into trials if your institution is involved in a trial. And I found that once someone does not respond, being able to clearly document the reactions they had, whether that was allergy or an allergic reaction to an infusion, or whether it was just complete lack of response, I have been able to get those other medicines for children once they've not done well on what is covered. And so that part seems to go a little bit better, but you have to go through that first one, unfortunately.
So we've talked about this idea of the individual person accessing these medications, and now we're going to look out from ourselves and look at the community around us and ask the question of how do we make sure that everyone else can get the medications that they need to. And this brings up this issue of advocacy, which I know the three of you are big champions for. And Marquis, I'm going to start with you and the amazing Koji organization that you work with and all the work you do personally. Can you talk us through some of the advocacy work you all do and why that's important to you?
Yeah, absolutely. So just a couple weeks ago, we participated in Advocacy Day on Capitol Hill, which is a big day once a year where a lot of advocacy groups get together. And, we're taking to the Hill. We're meeting with our representatives. We're meeting with our senators of our respective areas. And, we're advocating for these bills like STEP therapy and Medical Nutrition Act and, all of these bills, bipartisan bills, that everybody can get behind to alleviate, these things like we're talking about, with failing medication before you get, prescribed what your doctor is recommending, making sure that we have things like Ensure and these oral drinks that, IBD patients, people with these illnesses rely on, in terms of making sure that insurance are covering these things as well. And so this is something that we do all the time. We have training on it, and just really teaches us to use our story, to talk with these legislators to back these initiatives. Again, because everybody has family members that's sick. Everybody has family members that, uses medication, all these things. And so that's one of the big advocacy efforts that we do and that we participate in annually.
What about you, Dr. Jordan?
Yeah, so I'm particularly involved with the Crohn's and Colitis Foundation. My advocacy journey is a little interesting. I really got involved in my third year of medical school. I was on my internal medicine rotation and, at that time didn't really know anything about advocacy, didn't know much about politics. I voted, but I didn't know anything else about politics really. And I was in the hospital, I'm in the rotation, and I was taking care of some IBD patients, and a big issue that kept coming up was public restroom access, which was something that I was really surprised about because coming from Michigan, I knew that we have a law in Michigan, Allie's Law, or the Restroom Access Act, which ensures that IBD patients have public restroom access. And so I was wondering, why is this an issue here? I was in Georgia, and I looked it up and found out that unfortunately there are a lot of states that have not passed the Restroom Access Act, and so this is an issue in a lot of other states. And so I wanted to know how big of an issue it was, and so I did kind of the medical student thing and tried to do I did a research project. So I surveyed IBD patients in the hospital and asked them about had they had issues with being denied restroom access, had they had accidents because of that? Did they know about this law that existed in other states? And if that law got passed in Georgia, how would that change their life? And unfortunately, over a quarter of those patients had been denied access and unfortunately had had accidents as a result of that. And many of them didn't know about this law. Probably over 90% of them didn't. But when told about this law, they said, this would completely change my life. And this was even pre-COVID. They were telling me that they're stuck in their homes because they're afraid to go out because they never know if they're going to be somewhere where they're denied restroom access and then have an accident and soil themselves. And so not really knowing what the next steps were, I took this research and I said, this is an issue. And I went to the Georgia chapter of the Crohn's and Colitis Foundation and said, restroom access is an issue here in Georgia. We have to do something to help IBD patients here. And they actually connected me with another advocate who was interested in the state, and she and I were able to work together to convince her local representative to take this bill on. And we actually were able to get the bill drafted for the first time in the state of Georgia, which was very exciting. And I was able to work on that for 2 legislative sessions and learned a lot through that process, really about advocacy, about lobbying, about kind of all of these things around what does it mean to really, take that next step in terms of going from research to action, as we've been talking a lot about today. And so that was really my first kind of jumping off point from that. And then since I've been back in Michigan, I've been working a lot on the STEP therapy reform. That's been passed in a lot of states. Unfortunately, Michigan has not passed that, but
Can you explain that a little bit for the crew?
Sure. So STEP therapy is sort of a lot of what I was talking about previously, and unfortunately something that I've experienced where, there's a medication that your physician wants, to put you on, or you may be on a medication and you're being kind of, that process of being forced to trial a different medication or trial particularly an inferior medication to the medication that is being recommended for you, because that's the medication that the insurance company is saying that they want to cover. Usually it comes down to a cost-related thing. And so step therapy reform will really change that process and allow, it really will be life-changing and allow kind of taking some of that power away from the insurance company and putting it back into the hands of patients and providers, where a lot of that shared decision-making that we've been talking about would come back more into play, because there would be more opportunity for those medications that are being recommended to actually be covered. And so to kind of put that briefly in a nutshell. And so that step therapy reform has been passed in a lot of states, which is wonderful. It's not been passed in all states, and Michigan is one of them. And so that's something that I'm working on now, is like there's a bill in process now in Michigan that we're hoping that we see passed for step therapy reform in Michigan. So I'm working on that with the Crohn's and Colitis Foundation right now, as well as the federal bill is one that we're all continuing to work on, because ultimately, even if it's passed at the state level, we need to pass at the federal level for really everyone to see the most benefit.
Dr. Falaiye, for you as a provider, what's been your experience with advocacy?
I've had quite a number of different experiences, so I'll list a few. As a pediatric gastroenterologist, I think kids often get forgotten. Things are designed in general for adults and then adapted to kids. And so we want to make sure kids are not forgotten, and I do that in a number of ways. I have participated on Day on the Hill with the Crohn's and Colitis Foundation and with the AGA. I also participate with the Crohn's and Colitis Foundation in a number of roles, including helping kids get to what's called Camp Oasis, which is a summer camp where kids can meet other kids who have IBD, realize they are not alone, and that they can still be a kid. There are other organizations that do these summer camps as well, and the Crohn's and Colitis Foundation actually recently published a paper that demonstrated that kids who went to these camps had more self-efficacy in terms of, or self-management. They were more willing to take their medicines on their own. They were more knowledgeable about their disease. Having been the camp doc at some of these, kids ask great questions. Like, how many times should you poop a day? And I'm like, that's a great question, bud. That they may not ask when their parent is in the room or when they're in a visit. And so really getting to experience life with other kids, and kind of that it's okay to take your medicine and then you go on to your next activity can be really life-powering for them. Also, as we discuss with our adult colleagues, kind of that reminder of between medication, between when we design these therapies, the Medical Nutrition Act actually impacts kids quite a bit, both through enteral nutritional therapy, which is the idea of using a liquid food to heal the intestine, specifically for people with small bowel disease, but also recently shown to be very impactful before surgery, as well as kids who are born with medical problems where they have to do a specific, very specific type of diet to prevent brain damage and other things. And so that definitely affects pediatrics much more so than adults. And so through these different ways of working with adult colleagues, working with the Crohn's and Colitis Foundation, working with the advocacy groups, the goal is to let people know that kids also get IBD and kids still want to be kids, and we want to make them as healthy and as kid-like as possible.
All right, so as we land the plane here, we can't do so without recognizing the fact that inflammatory bowel disease is not just a disease of the bowel. It has many manifestations, including its impact on mental health. We could never give this enough justice in terms of time, but let's try. And so, Ariel, do you have any, maybe you can talk us through some of the research work that you yourself have spearheaded on this front with IBD patients and depression and other mental health illnesses.
Sure. So in medical school, I did a research project related to depression in African American IBD patients, and unfortunately found that over a quarter of those patients had quite severe depression, but even more were not even being screened. And really that is the crux of the issue, is we're not we're not screening our IBD patients for depression, for anxiety. And I've continued to do similar work at the University of Michigan, looking at anxiety and depression in socially vulnerable patients, and really, maybe not surprisingly, our patients who are have the highest social vulnerability are those with the highest rates of having diagnosis of anxiety and depression. And it really comes down to the question of whose responsibility is it? Is it primary care's responsibility? Is it GI's responsibility? Is it the patient's responsibility? Whose responsibility is it to be making sure that mental health is being managed? And I want to say it's everyone's responsibility. We've all got to really work together to make sure that this is important. Part of managing IBD is also managing mental health, and so it's not okay to have your patients never have been screened for anxiety, never have been screened for depression. And so I want to say that, for our providers, it's important for all of us to be screening our patients. It's really easy, it's really quick. A lot of these screening questionnaires, the PHQ-9 and the GAD-7, they're really quick and easy questionnaires. If you don't have time, we can start with the PHQ-2 and go from there. And so they're really easy tools that we can be using in our clinics. And it's the next step of that, though, is not just doing the screening, but asking about it. Like, if you see that, a lot of times it's built into a lot of our EMR systems, you have to ask about it. We can't just screen them and see that red severe depression pop up and then kind of gloss over it. We have to say something. We have to say, how are you doing? What can I do to help you? Let's talk. How are you feeling? How is your IBD affecting your life? And, really just asking some open-ended questions and really starting that conversation. And I guess on the patient end, because I have to always put on my patient hat too, for my patients out there, I want you all to know that you should feel empowered to talk to your doctor about this. If your doctor is not bringing this up, but you are struggling with your mental health, bring that up to your doctor. Any of your doctors, whether it's your primary care, your gastroenterologist, it shouldn't matter. Tell them, in that visit, when they're going through all of the other things they want to talk to you about related to your meds and adjusting your meds and all of that, tell them, I just want to talk to you about it for a few minutes about how I am struggling coping with my IBD and I need help. And they should be providing you with resources for the next steps.
Marquis, what would you tell that patient who is going through a tough time about how to empower themselves in the middle of fighting this illness that they've been diagnosed with?
Yeah, great question. I would tell them that this is not the end, right? This is not the end. So, I said I've had the Crohn since 2009, and, I live with the motto that I have Crohn's disease, it doesn't have me, right? What does that mean? It means I have Crohn's disease. I acknowledge, yes, I have this disease. It doesn't have me means I'm going to control the controllable. That's within my control. And Crohn's is just going to have to come with me, right? And so from a IBD patient standpoint, why I do a lot of advocacy work, I always challenge us to control the controllable while we're waiting for change. Because if anything what advocacy work has taught me is that change takes a while, right? Coming to Hill Day year after year and following up on fail first things that's been in the pipeline for years to see where the progress is, it just opens up the eyes that, again, while we're waiting for this change, what are we doing in the interim, right? We can't just sit and wait for the change to happen but not be proactive in what we can do while we wait for this change to happen. And as we seen earlier, with the honorary speaker, it doesn't take much. We're talking about 150 minutes minimum exercise breaks down to 20 minutes a day. And you don't even have to get outside. You can do it in your house. It's just those little things that once we do it consistently turns into habits, then it turns into a lifestyle. And that will be tremendous on our health journey, living with IBD. So it's not over, but you have to do your part and control the controllable while you're waiting for change.
Dr. Falaiye, oh yeah.
Can I have one more thing? I just wanted to say too, this is something that I've seen over the years as someone who is both a provider but also living with IBD. If you're someone out there who is both a patient and provider like me and you feel comfortable, tell your patients. I tell people that I understand, and I remember the first patient that I told, she and I were having a conversation. She was recently diagnosed, and she said to, she stopped me, and I was trying to explain something to her, and she stopped me, and she said, honestly, like, what do you know about this? What do you know about how I feel? And I told her, I do know how you feel. I've been there. I've been in your shoes. And so, I think I've met a lot of people who are like me who have IBD as well, and they're a provider, and it's kind of this whispered in the shadows kind of thing. But I think if you're comfortable telling your patients or comfortable talking to other providers about, hey, I have this too, there's a network of us out there, and I think we can also be a community for each other and also a community for our patients so that they know that, you are not alone in experiencing these issues. I am frustrated that they're not covering your meds too. I've been there, and I have not had my meds covered.
All right, Dr. Falaiye, you get the final words on this issue of mental health and IBD. Any notes to either parents or providers on this issue?
Yeah, I actually screen all my patients annually for anxiety and depression, and there are validated screens for children for both of those things. And I think it's important to bring up that saying someone's sad because they have the disease, it might be more than sadness. It might be true depression that needs to be addressed. There are GI psychologists who can help us address this. One of the big challenges that we didn't have time to get into is payment. It took 6 years for us to get our GI psychologist, and we've been working that whole time trying to get this covered. But there are resources out there, and as we've been able to add resources in our multidisciplinary IBD clinic, people are getting these things addressed. And sometimes I go in and I'm worried the parent is depressed, not just the kid, because this is really difficult, and people feel guilty that they pass this on to their child. And so it is not just something that affects the one person in the family, right? Every time the toilet flushes in the middle of the night, the parent often wakes up and hears it. And so we may need to address the whole family, not just the person who has the disease. And so this is a really important issue. We do know if you have anxiety, depression, which by the way is 3 times in IBD, the rate of baseline population of non-IBD patients, you're less likely to be able to take your medicines, you're more likely to end up in the hospital, your flares last longer. There's a whole bunch of comorbidities that go along with having anxiety, depression that are not gonna get better if we don't do something about it. So I don't prescribe antidepressive medicines, but I definitely look for it. And when we see the signs, even if it's, hey, your screen is worse than the last year we took it, we're gonna take active action to get that addressed the best we've got based on where you live to make sure that we're taking care of the whole person, not just the gut.
Let's give them a round of applause, please. All right, so I've completely blown through our time schedule here, but we'll take 1 or 2 questions. Have one from Dr. Smith, and we can tee up our second one here, and we'll have to end it there.
So Dr. Iroku, I want to challenge you and the panel and perhaps the whole room a little bit. As I think about this as an esophagologist, there's certainly over the years, I think to some degree a little bit improved, but still a large number of people in practice who grew up in their medical training and in their practice hearing that IBD was a disease not at all in the African-American Black community. And I think as an esophagologist, I hear that with eosinophilic esophagitis, with Barrett's esophagus, that these are not diseases that Black patients should get. And that delays diagnosis, it increases suffering, it decreases the knowledge of patients who treat of providers who treat this population of patients because they're not as aware. They were told this isn't important, you don't have to focus on this. And I think it affects adversely the quality and the efficiency of the care that we provide in this field. And I'm wondering what organizations like ABGH, what the advocates that we are working with, all of us as providers can do to release and reverse that bias against thinking about these diagnoses and our differentials, and make sure that we open eyes to realizing that patients of all types can have these diseases, and we need to be thinking about them from the outset and not as a backup when the other things we're thinking about fail to be manifested as the actual answer.
That's right. So he's referring to the fact, of course, that over the last 40 years, the incidence of IBD has increased on the tune of about 10 to 20% in Caucasian communities, but 100% in Black communities. And so I'll let you tackle this one. Any thoughts on how to empower our primary care physicians and our GI doctors in terms of early detection of this disease that's very much dependent on early detection?
Yeah, I think a big part of it is, one, we finally have research that outright says and shows that this is a disease that does not just affect, Caucasians, that this is really truly a disease that affects everyone. And I think, but the next step of that is really the education piece. It's really, getting the education out there to all gastroenterologists, even gastroenterologists who are not even, specifically seeing IBD, and also primary care, really just getting the word out there that, this is a disease that affects everyone. Like, you need to have IBD on your differential if you have somebody coming in with these symptoms, and I think that's really probably the first step.
Yeah, we're not sure if we're going to find celiac disease or colon cancer, early onset colon cancer, or IBD, but whatever it is, at some point, it's time to do the workup. All right, our final question.
Thanks for your insight. Actually, please understand me as I'm not an English speaker. So I'm Ray Park from Celtrion, and as a clinical data manager with experience in clinical trial for Crohn disease. I also believe, like Dr. Falaiye, there is a need for more options for pediatric patients. So I just wonder that from a clinical trial preparation perspective, I understand clinical trials are essential for approval. So conducting trial with pediatric subject is very challenging, such as consent, or they are some kinds of vulnerable like that. So could you provide advice or consideration for preparing pediatric clinical trial? Thank you.
Yes, absolutely. So I think the first barrier to pediatric trials is a little bit of fear on behalf of the drug companies, and I think that fear is improving as there's been more advocating to them to say this is necessary, these patients also need treatment. And so the next barrier is, as you said, pediatrics are a protected population, and so you, depending on the type of trial, need assent from the patient as well as consent from their guardian. And the trials are very specifically designed. So it tends to be either weight-based or age-based. And we could go into this. This is a whole thing on its own. But I will tell you that as the IBD centers, the pediatric IBD centers, are very much involved in these research trials. Another barrier that is separate from the regulatory side and the financial side is that there are fewer pediatric patients. So even though 20% of patients, 20 to 25%, depending on which study you look at, who have IBD will be diagnosed before the age of 20, that number overall is small. So trying to get enough patients so that you can power your study and really demonstrate improvement is challenging. And there are some groups working on that. So Improve Care Now is a large IBD consortium, international consortium that works on that to get enough patients in so that you can power your studies well. The Crohn's and Colitis Foundation has a study that is starting up called Capture, same kind of idea of trying to gather patients from multiple centers so that you can power research studies appropriately. So it is being worked on. But yes, there are clear challenges, but it's getting better.
All right. Another round of applause. Thank you guys so much.